India. Dr. Gyvi Gaurav is going to speak on is a general urologist becoming extinct.
Good morning, everyone. Thank you for having me. It's really exciting, and I don't know how exciting it can be to talk about extinctions, and especially after burnouts, but here I am. Is a general urologist going to become extinct? Are we going to be the dodos of urology? I have no disclosures, and so I'll be talking in the following flow. Who or what is a general urologist to be defined first? Why is his survival an issue? Is the alternative indeed a panacea? And are there any other threats that we are looking at? And finally, we conclude. So who exactly is a general urologist? Now, there are no definitions. There are no work which is assigned to a urologist in general. So before we answer the who or what, we need to answer the where. The Mount Sinai versus the Mount Abu question. Mount Abu is a small hamlet in Rajasthan, India, my country. It's a tourist place. A general urologist in a hospital like Mount Sinai will be a super specialist in a place like Mount Abu, where the number of doctors totally may not be equal to the number of urologists in the department of Mount Sinai. So where becomes a very important question in defining who is a general urologist. So for our purposes, a general urologist, let us assume him to be somebody who has a finger in every pie. And to paraphrase Pellegrini, a relatively undifferentiated, theoretically pluripotential individual who can perform most urology, stones, prostate, 60-gram glands, TRBTs, etc. And in the same vein, who is not a general urologist or a subspecialist, is a wholly differentiated, theoretically unipotential individual who can or will perform only subspecialty urology. A gentleman who's at home doing a radius-sparing radical prostatectomy but refers away a 2-centimeter pelvic stone. So why is the survival of the general urologist an issue? Are we going out of demand? Actually, if you look at the numbers, we are going out of supply. The US projected workforce study shows that there is going to be a shortage of urologists as we proceed. It is contributed by what is known as a silver tsunami, the aging of the general population of the world, as well as the aging of the urologists. So we are looking at the numbers going down from 24 per 100,000 to almost 13 per 100,000 in the US. And they are going to require an additional intake of 100 urologists per year just to meet that kind of shortfall. There is a similar downward trend in Europe. The numbers from Canada and UK and India aren't very good either. In India, it's almost preposterous, 1:500,000. 500,000. But this data is culled from various sources. So in this scenario, the general urologist should be flying off the shelves in the future. Why are we even talking about extinction? Is this distribution the key? Urologists, after probably having spent all their lives specializing in something, prefer to be in good key prime cities, the good metropolitan locations. And this leads to a skewed distribution. If you look at the chart of the United States of America, there are huge white spaces where there's not a single urologist available, almost more than 60% of all their counties. And it's not as if the younger urologists are going and filling these gaps. The younger urologists are even less likely to be found in the non-metropolitan locations. Lifestyles have started defining career choices. Even climate was found to be a predictive factor in where they're going. You get paid the best in Alaska, so it's not as if people are going for financial incentives. A similar story exists in my country, India. The 100% of urologists practice in what are known as Tier 1 and Tier 2 cities. And these Tier 1 and Tier 2 cities comprise of just 99 out of 4,000 cities in India. That's 0.02% of the cities. So this skewed concentration of urologists in one place, coupled with more and more intake of new urologists, is probably causing a traffic jam on the Mount Everest. Too many people in one place. And this supersaturation combined with the lack of dispersal to people to peripheral areas is leading to a kind of a bottleneck. And here, the urge for a subspecialized position is probably a shorter route to a consultant position. And thereby, this quest of fellowship and thereby subspecialization. We have to question, is this the real thrust behind the subspecialty push? And is that all, or is there more? So if you look at numbers from residents from my country as well as consultants from UK, they are listing endourology as the subspecialty that they want to specialize in, almost 30%. And I'll talk about these 40% also, the people who want to specialize as a subspecialty in laparoscopy and robotic surgery. So if you look at the consultants from UK, they are also listing endourology as their subspecialty. So what indeed is general urology if it is not even endourology? Look at the numbers on the ground. Across 3 tertiary care hospitals from Delhi, my country, AIMS, St. Stephen's, Sir Gangaram, which cater to a different volume of patients. An astonishing 60 to 70% of the procedures that are being done are what is known as general bread and butter endourology. Similarly, according to the Bausch Urology workforce, in 2021, the number of ureteroscopies, TURBTs and TURPs were 3 times more than all the other procedures combined. And the other procedures include 15,000 ESWLs. So we are looking at something where general urology is being performed by general urologists. If it is not endourology, then what indeed is it? Also, the laparoscopy and robotic surgery subspecialization. Laparoscopy is a skill. Robotic surgery is a skill. And skill acquisition does not equate to subspecialization. Skills can vary across subspecialties. You know, my favorite question is that if you have a stone in a transplanted kidney, who takes that out? An endourologist, a general urologist, or the transplant surgeon? And the answer is whoever has the skill. So skill acquisition is something which is good, but it only makes a general urologist more skilled. It does not make him extinct. And whichever subspecialty is based only on technology is bound to become extinct when the technology becomes obsolete. Take the example of our ESWL. It was once hailed as the biggest technological marvel of urology. Today it is almost on the verge of extinction by the ureteroscopes and their more flexible counterparts. Imagine a time when there's a pill which takes care of localized as well as local prostate cancer. What happens to our terminally differentiated robotic surgeons then? Do we need some general urologists to step in and take care of this then? So this subspecialization, is it indeed a panacea? I have some questions, these are just questions to ponder over. How many fellows are actually absorbed in their parent institution? Not many. They move out. How many will migrate to setups where their subspecialty is already developed? Not many again. And what will they practice till the time they are able to establish themselves? General urology. So they have to have some basic training in general urology. And when you have moved to a non-metro location, will it be prudent or financially possible to maintain a purely subspecialty practice? You will get a huge number of patients. So these are the questions one has to ponder when we are thinking about subspecialty. And one major thing which is attributed to subspecialty is volume. More volume, better outcome. While this is intuitive and probably correct to a certain degree, there is no urological literature which establishes clear volume thresholds. And individual surgeons can differ in terms of their volumes. Lower volume surgeons, when they are put in high volume facilities, seem to give equal results, if not better. So the volume of patients is almost equal to the volume of the team that contributes to the results that you give. And thereby, this volume has also to be kept in mind when you are talking about a general urologist going extinct. If he is made to perform in a team, he is going to thrive, not go extinct. Are there any other threats that we are looking at? Well, welcome to the world of AI. My friend Dr. Zishan has many review articles about AI and general urology. And ChatGPT, when it was made to give the USMLE, scored 60%, almost without any preparation. And a recent study shows that it answers the patient's queries better than most urologists, and it's more empathetic. So are we looking at a time when you have a general virtual urologist? Well, when it was put to test, it didn't fare very well. ChatGPT had only 30% responses which were correct, and indeterminate 30% response, and worryingly, it kept providing consistent justifications for incorrect answers, like those stubborn trainees who will not let go. Now, this is early, these are early days. Are we clutching at straws? Because if it trains more, it becomes better and has more information. What happens then? Will it be able to replace a virtual general urologist? Will this be us in 2080 or maybe even sooner? I did not know, so I asked ChatGPT. And thankfully, thank God for small mercies, it said very emphatically that no general urologists are not becoming extinct. And they will be required to be an important part of the medical field. So to conclude, dense clustering in metro locations might be driving the impulse to subspecialize, giving an impression that the general urologist has become redundant and even extinct. And while this gravitation to subspecialization is a natural phenomena, but it should be driven by science, not technology. And a general urologist is actually likely to be required in larger numbers in the future due to the growing demands of an aging population. And as far as the general urologist's extinction from AI is concerned, I'll leave you with a slightly humorous take on the last answer. Well, general urologist going extinct, not a chance. We are the unsung heroes of the bathroom and the Sherlock Holmes of urinary mysteries. We are here to keep your liquid assets flowing freely. Thank you so much.
Thank you very much, Dr.